Syndactily release is one of those topics where everybody has their favorite methods, I think. But I'm not really aware there is in the literature that there is one superior technique over all techniques. So I'm really going to just focus on the principles here. So we all know how to classify syndactily. Other than the usual complete, incomplete, simple, complex, I find it quite helpful to find out if these are border syndactylies or complicated syndactylies. And that's how I tend to want my juniors to classify them. And the principles of management are well established. I'm not going to spend too much time on this. There is insufficient skin to be shared between two fingers, so you need to recruit skin from somewhere. The idea is to recreate a normal finger as much as possible, avoid longitudinal scars, create a good web, use interdigitating flaps, use flaps in the web space to reduce web creep, and full thickness skin graft for non-critical areas. So this is a short video really just to quickly show how I do it, in case there are any junior surgeons in the audience. I mark the joints, I divide the distance between the MCP and the PIP into thirds, and my dorsal rectangular flap runs from the proximal 2/3 to the distal 1/3, and these are the interdigitating flaps. And what you're trying to do is to create a mirror image. Different ways you can do this. I just usually just remember which direction I place the flaps at the joints, and I make it a little V at the palmar aspect of the web space, so I don't get a straight curve, and that may reduce the incidence of web creep. I don't know. Again, the literature is quite inconclusive about that. So let's go on to this. Why do we need skin grafts? Because when you use a standard rectangular flap, you will end up with two areas, raw areas on either side of both fingers, which cannot be covered. And because these are predictable areas, we can design where skin can be recruited for skin grafts, to substitute for skin grafts in the graftless technique, usually from the dorsum of the fingers, or as we shall see later, from the dorsum of the hand. So there are many designs for, so this is typically where you will see the skin grafts after a dorsal rectangular flap technique. There are many different ways of designing a graftless technique. This is a technical talk, so I'll focus more on the techniques. So again, just to say that to cover the areas, we need to know where the deficiencies will be. As I mentioned, these are typically at the base of both digits. And so to recruit the skin to cover this, we typically take them from the dorsum of the finger or dorsum of the hand. Really the important message to say is that there is still a donor site for covering these areas. When we say in the graftless technique, there is no donor site, there is still a donor site, except the donor site now is on the finger and the hand, and they can be as noticeable as or problematic as taking a skin graft from a distant site. So there are many different methods of doing a graftless syndactily release. These are essentially variations on a theme. So to cover the areas, we could take triangular extensions from the dorsal rectangular flap from the dorsum of the fingers. This is well described by Hank Gill. This picture is in Green's hand surgery. Now, the important thing is to know that this will leave quite a significant scar on the dorsum of the fingers. And I know of at least one publication where the parents do not like this. So we do have to bear in mind this. Anything dorsal on the hand is quite visible in my opinion. And we should think carefully about that. Another variation is the dorsal pendangular flap, which is essentially an islanded advancement flap. And because the flap is advanced from the dorsum of the hand, we can then recruit, this is described 1998, because the flap is advanced from the dorsum of the hand, you can then recruit more skin from the digits and then essentially close all the raw areas. But it's important to note that this will again leave a scar on the dorsum of the hand. So if not on the fingers, then it will be on the hand. So we have to think carefully about this donor site. I think these considerations are important in terms of the donor site, and there are also other considerations. So I think it's important to think about whether the graftless technique can be used in cases where the vascular anatomy may be unpredictable, and therefore I don't really use them for simple in cases in which it is not a simple syndactyly. In older children, again, I'm very careful about using the graftless techniques because the fingers have grown and the morphology of an older in the fingers of an older child is different from that of an infant. And often I find that the skin doesn't stretch as much, and I would need skin grafts to cover raw areas. And also in the burn hand, the syndactylized burn hand, or where there is excessive scarring, I think it's important to consider maybe a graft technique rather than a graftless technique. So just to mention about the vascular anatomy, so usually the bifurcation is proximal to the web space. So I know I can dissect all the way down to the web space, and the dorsal rectangular flap or any other flap design between the MCP joint and the PIP joint should be able to cover the web space reliably. In a condition like this, the bifurcation may be distal to the web space, and obviously you can clamp one and see what happens. You can do microvascular repair, like what Jin Shen has described. But generally, I think it's important to have some flexibility. So I will use the combined dorsal and palmar V flaps because I can adjust the position of the web space to accommodate the bifurcation to make it more distal. And if you use this combined dorsal and palmar V flaps, you will end up needing skin graft, and that's quite important. So in this cases where I think that the vascular anatomy might be unpredictable, I would usually not use a graftless technique. So another scenario, if I see a finger like this, I'll be thinking that perhaps the distal bifurcation may be unpredictable. And definitely, I will not use the graftless technique in sympodidactyly. And then, as I mentioned, older children, so this is an older child, he's about 8. Again, I try to use the graftless technique, and I extended the flap all the way down to the dorsum of the hand, and really it was a stretch. The finger eventually healed, but I think in retrospect, I would have used a graft technique. So what does the literature say? Which is better, graft or graftless? Again, there's many papers out there. I'm not going to spend too much time on this because this is a technical talk. This is one paper, 2019, Journal of Hand Surgery European. They compared the skin graft versus graftless technique, the same patient. And overall, the results show that in terms of web creep, the full thickness skin graft, when I say greater than, I mean better. So it's better for the full thickness skin graft. It's better in terms of scar score. It's better in terms of parental appearance, parental rating of appearance, surgeon's rating of appearance, and therapist rating of appearance. So there may be a longer tourniquet time with the full thickness skin graft, but the use of grafts may be advantageous in appearance and web creep. So it seems pretty conclusive that we should use a graft technique until we look at the technique that they use for the graftless technique, and that is again a pentagonal flap. And this will leave a significant scar on the dorsum of the hand. So I don't know whether that was a factor in the parents, surgeons, and therapists rating this to be a more be a less aesthetically pleasing outcomes as compared to the dorsal rectangular flap, which is a graft technique. I think this definitely warrants a closer look. This is another paper looking at the comparison between skin grafts and the dorsal metacarpal advancement flap. And interestingly, in this paper, they found that skin grafts result in higher rates of early postoperative complications in all aspects as compared to those using dorsal metacarpal advancement flap. This is what I meant by how the literature is so confusing. And the conclusion is that the simple syndactyly reconstruction of the flap may lead to fewer complications. Now, I was very interested to see what the aesthetic comparison would be, but there were no aesthetic comparisons made. So I think the jury is still out. So what do I do? So I make sure I choose the right patients as mentioned earlier, get the indications right. So I don't use it in all patients. And in terms of techniques, I have experimented with different techniques and thought long and hard and finally settled on something which I think is the best balance between skin recruitment and dorsal scarring. This is the technique I use. It's originally described by Niranjan. It's probably known as also the tri-lobe flap or the seagull flap. There are many variations. And I think in the original paper, it wasn't described very clearly how the different pieces fit together. So I thought I'll spend more time in this technical talk on how to get the best result, the most reliable result from this. So this is the video I'm going to play and show. So this is the marking. Again, it's similar to marking of a simple rectangular flap. I mark the joints, and then I divide the distance between the MCP and PIP into thirds. And this is the seagull or flap design, or the tri-lobe flap. And you can see what I'm trying to show here is really that the flap doesn't go beyond the mid-axial line. So the eventual scar will be similar to that of a dorsal rectangular flap. So it doesn't extend again across the whole dorsum. So it's much less noticeable. So it's essentially a dorsal rectangular flap, but the seagull is enclosed within that. And then the rest of the marking is as what you would do for an interdigitating flap. In a older child or longer finger, I tend to mark more flaps, and this is the modified Bart-Kremko flap that most of us should be very familiar with. So that's the design, and then in terms of the dissection, again, nothing much to say about the initial flap. Raise it as thick as you can. And this is really what I want to show, the importance of using every single aspect of the laxity of the skin, because this is what allows the graftless technique. And maybe as you just come back to that again, and maybe if you think about a dorsal rectangular bed or a triangular flap it recruits a lot of skin from the dorsum of the hand, but if you can really utilize the laxity of the skin in all directions, and maybe that is all that is needed for a graftless technique. So that's what I really want to show here. And then dissection down to the peritoneum. And again, this is another very important trick. I'll just come back to that again. So yeah. Sorry about that. Yeah, so the important thing here is to, once you've raised the tri-lobe flap, that the bottom end of this wing will fit into where you previously cut it from, and you just fit it up there. And once you get that piece in there, the whole thing just falls into place. And I think that wasn't very clear from the original publication, and that's really what I want to highlight in this talk. And I'll show that in more detail later. So yes, there you go. It just fits into that corner, and then the whole thing should fall into place. And so again, this is the release of the Syndactily going down to the web space, and really the extent of defecting that is necessary for this to close primarily. So whatever technique you use in the graftless technique, you will have to do pretty significant defecting. So here again is to reinforce the markings, MCP, mid-axial line, divide the distance between the MCP and the PIP into thirds, and the flap will just fall into that small area. And important not to extend into the mid-axial line. So your scar is just going to be across halfway across the dorsum of the hand, and that will keep the scarring to a minimum. And that's the seagull, and then the interdigitating flap. Again, just to reinforce where the bits fall into place, the bottom end of that wing will fit into where you previously took it from. And once you understand that, the whole flap will just fall into place. So again, this is for a complete syndactily. So so the first stitch will bring the superior part of the seagull flap into the polar aspect of the web space. And then this is what I usually do. I will put a silk stitch just to hold the finger upright. And this is where we start to fit all the pieces in place to get the closure of a graftless technique. So again, reminder of the lower end of the wing, fit it into where you took it from previously. There you go. So once you put it in there, you can see immediately how the whole thing is going to come together. That can be closed. and then the flap from the palmar aspect can be brought into to close the other side of the wing, as you can see here, and then the whole thing just falls into place. So I think that is really, really key that I felt was missing in previous publications, and that's why we published that paper in the techniques of upper extremity, and that should get a reliable closure every time in the graftless technique. And the scar, as you can see here, is really limited to less than half the finger. The other problem I have with taking an entire flap across the finger is that sometimes I encounter venous congestion. I may have to release quite a few sutures in order to get a better venous return, but I don't really get that in this design. So that's the kind of results you can get in long term. This is the complete syndactily. You will get some raw areas when you release the syndactily in the first instance, and they usually heal very well. But I would recommend doing this syndactily as early as possible, because as I said earlier, in the older child, it's harder and harder to get all these raw areas closed. Just really to end that you can start to vary your techniques once you understand the principles. So for a hand like this, I will be slightly worried, as I said earlier, about the abnormal vasculature, because this is not a simple syndactily. However, I'm not too worried about this syndactily. So I use a graftless technique for this, and I use a graft technique for this. So it's, again, to me, I think the important thing is to really understand the principles and not just stick to one method. And really just to end with this very, very unusual condition. This is a syndromic child, and I'm thinking this is the left-handed child, it's a girl. And I'll be thinking, if I'm gonna leave any scar, I want to leave all the scar on the little finger, because this is a wedding ring finger. So I design my flap based on that. And so the scar goes onto the little finger, but the ring finger is devoid of any scars, because that will look better on a wedding day. So again, in conclusion, so the graftless technique, I think, should be used primarily in simple syndactily, complete or incomplete. You got to be careful using it in complex syndactily. I think I'm sure there'll be a lot of disagreements about this, and I look forward to the discussion. I think it's important to get the indications right. In terms of technique, there are many, many techniques. My preferred technique is to get a balance between the dorsal scarring and the donor side scarring. And I think we can vary the techniques to optimize the results, but the important thing is to understand the principle. Thank you.
That was very nice, Dr. Lam. And I think very rightly you placed it that we need to correctly cater the indication to the type and severity of the syndactily what you have. So in your clinical practice, how often you would be able to do this graftless technique?
I think thankfully, the majority of our syndactily are simple third web syndactily. So you should be able to use this technique reliably on every single case of simple syndactily, but preferably in younger children, so less than 2 or 3. And I think it should be quite a reliable technique. Once you go above 4 or 5, fingers become quite long, and I think you probably will struggle a bit. Again, this is not mentioned very much in the literature, because what we are so focused on is just one technique, and we become quite dogmatic. But I think it's quite important to really vary the techniques according to the principles.
Yeah. How about the rules of doing it in more than one fingers, like adjacent webs? Do you have any considerations for that? Like suppose there is a syndactily multiple. Yeah.
Yeah, I know that's been well described. I think it's Harvey Chin's paper. I can't remember who the other authors were, where he used the seagull flap on all 4 digits at the same time. So I personally wouldn't do that. I think you have difficulty recruiting the skin. I think you will stretch the skin in different direction. Again, my main concern is that I'm worried about abnormal vasculature. So once you design a a graftless technique, you need something like a dorsal rectangular flap. You're pretty stuck if your vessel is quite distally bifurcated.
Yeah, true. Are there any questions from other participants?
So I just have a comment, if I may.
Yeah, Dr. Dan.
Yeah. Thank you. Lovely to see you. Thank you for your talk. So one of the things that Jane Shen talks about is this sort of, she'll do everything at the same time, which obviously goes against everything that we've been trained to think about for a long period of time. But the whole idea is and in some ways it's kind of elegant in that you elevate the entire dorsal hand skin and everything shifts forward. And in some ways, I think that it's different than differentially sort of taking one, the skin behind one digit and moving it. You're moving the whole thing. And as you showed, there's quite a bit of stretch in the skin. So I think that my concern has always been vascular egress, as you pointed out, is do they get venous congestion after that? I don't know what her complication rate is. I don't know if it's something, the thing about Jane, having operated with her, she is a tremendous surgeon. She's incredibly precise. And I always worry about techniques that work in the hands of somebody who's truly gifted. And those of us who are mere mortals, we may not be able to replicate her results. That's sort of my comment question.
Dan, I don't see you as a mere mortal. Well, yeah, I agree. I mean, Jane, I think, she's incredible. She pushes the boundaries. And I think really, we really need people like her to keep pushing the boundaries. And who knows? I mean, maybe in 10, 20 years time, what she is pioneering now will become routine practice.
Mm-hmm.
It's probably, like the ALT 20 years ago, perforated flap dissection. Now everybody's doing it, but it's so just look forward to what she's going to teach the rest of us, really.
Yeah, me too.
Thank you, Dr. Wee. I think there are not much questions there in the chat box. Okay, thank you everyone for joining. 3 very different talks covering different aspects of hand surgery, all 3 of them so useful. And I personally learned a lot. Thanks to all 3 of you. We'll meet next month again. Thank you so much.
Thank you, Praveen. Always lovely to see you.
Thank you. Thank you.
Thank you.